Welcome to the UK Dementia and Palliative Care Conference 2026 podcast, brought to you by Rowcroft Hospice. Recorded at the beautiful Buckfast Abbey Conference Centre in Devon, this series explores the critical role of dementia and palliative care in supporting those living with dementia. Across these episodes, we'll be sharing expert insights, real-life experiences, and innovative approaches to improving care. Thanks for tuning in. Let's get started. Just Let Me Choose: Eating, Drinking, and the Right to Decide. Presented by Dr. Anna Volkmer, Associate Professor, University College London, Psychology and Language Sciences, and Alison Smith, NHS Prescribing Support Consultant Dietitian, Committee Member, British Dietetic Association.
So my name is Dr. Anna Volkmer. I'm a speech and language therapist, and I'm really pleased about this wonderful theme of communication that has penetrated the entire day, because that is what I do. That's what I trade in, communication. I know that many of you will perhaps be more familiar with speech and language therapists in the context of eating and drinking and swallowing, and that's what we're going to talk about today. But the main focus of what we're going to talk about is actually people's right to communicate around what they want in terms of eating, drinking, and communication. And I'm going to hand over to my colleague.
Hi, I'm Alison Smith. I'm a dietitian. I'm a prescribing support dietitian, which probably tells you not a lot about what I do, but I've been an older person's dietitian for most of my career, and I have to say the thing that I've sort of basically from today is the fabulous food that we've all had at lunch and in the breaks, because I'm a dietitian who loves food and thinks that food is an incredibly important part of a balanced diet. So I'm going to be talking about that, but from the context of, exactly as our title says, letting us choose.
Brilliant. Thank you, Alison. So, I guess to really summarise, if you remember nothing else that in this late hour of this afternoon, please do remember that food, eating and drinking food, really, I think the main purpose of eating and drinking is not necessarily weight maintenance or nutrition. In fact, I'm hoping none of you were thinking about that today. I'm hoping that what you were all thinking about today was actually the pleasure, the conversation, the interaction, the quality of life that food gave you in the breaks, in the lunch breaks, around this conference, okay? And I think what we mustn't forget is that's also what people with dementia experience. They experience pleasure, socialising, interaction, and identity and autonomy through eating and drinking. They're not mindful of weight and frailty and chest infections necessarily. In fact, we've done some research, and I'm a researcher as well, and when we ask people with dementia what's most important to them, it's not eating and drinking and weight. It's being able to connect with other human beings. So I'm going to keep rolling this back to communication and connection, as Alison highlighted, because that's really the essence of how we want to reformulate your thinking around eating and drinking today. However, I am going to flag a couple of facts and stats to keep you awake. So we do know that swallowing difficulties are incredibly common amongst people with dementia. 58% of people with dementia have swallowing difficulties. That's probably quite a conservative figure, I'd say, in many ways. But certainly eating and drinking difficulties is something that I suspect many of you are familiar with in your roles when you're meeting people with dementia in care homes and at end of life. And what does this look like? Well, of course, if you've met one person with dementia, you've met one person with dementia, as Martin said this morning. And the swallowing function is very heterogeneous. People have different difficulties, but it can look like reduced coordination of the tongue. So people might have lots of food and drink left in their mouth, or hold on to the food in their mouth. They might have a delayed or incoordinated swallow reflex. So they might not be able to move the food and drink through their mouth, and it might go down the wrong way. They might not be able to taste the food and drink. They might not be able to put the food and drink in their own mouth. There are lots and lots of things that can go wrong in eating and drinking. And the risks, sure, there are risks around food and drink going down the wrong way. People might be at risk of pneumonias. So just to be really emphatic, food and drink going down the wrong way doesn't cause an aspiration pneumonia, it doesn't cause a chest infection, it just increases the risk of a chest infection, it increases the risks of weight loss, it does increase the risk of frailty, it does increase the risk of a reduced immune system, and it does increase the risk of death, of course. There are all those things to consider.
Lovely. Thanks, Anna. So, in a similar way, I'm going to throw a few stats at you, not particularly related to numbers, but from a nutrition perspective, the big things for me, unplanned weight loss. This is really common in all dementias, from pre-diagnosis all the way through the disease trajectory. This is a really common thing. So as a dietitian, I'm going to say one of the most important things for us to be able to do is to support people to start recognising the need to just get a weight and record it. And the next time somebody is seen, get another weight and record it. And talk to the person with dementia about their weight and basically ask, support them to maybe weigh themselves so they can keep a track of, are they losing weight without trying to? Because any weight lost without you trying to is not a good thing, regardless of what size somebody is to begin with. Unplanned weight loss is never a good thing, and it is never something that isn't happening for a reason, and oftentimes it is as part of the dementia. The other thing we know is that dysphagia, swallowing difficulties, exactly as Anna's described, is associated with absolute dehydration. We know this is much more common for people with dysphagia. And this is one of the other things to be aware about. Supporting people with drinking enough, regardless of whether they have swallowing difficulties or not, is incredibly important. But it's also extremely challenging, as we know, with all of these things. But it's a thing to look out for. And although with unplanned weight loss, with malnutrition, we have screening tools that can be used, which have their upsides and indeed their downsides. What we don't have is any screening tools that help us identify dehydration. None. And everything that you're thinking of, but we can use, ... none of them work. When it comes, there's no evidence for any of them, or in fact, the evidence shows that none of them actually work. So all of the bedside tests that we might think of as identifying dehydration, none of them work for older adults. So in the nicest possible way, we need to get away from thinking that those are great things to do. The key things that we really want to do, though, is we want to have early assessment and effective management of malnutrition and dehydration as much as we can. And generally speaking, the advice about dehydration is all older adults who are dependent on others are going to be at risk of dehydration. So that one, tick, we've done that, that's sorted. The malnutrition bit more complicated. But really what we need to do is actually collaborate and communicate. So remember those two words that came out of the last session, and I think have probably come up several times throughout today. Funnily enough, when it comes to nutrition, just the same thing. We all need to collaborate and communicate as healthcare professionals, as care professionals, as people with dementia, as much as able, and with relatives of people with dementia. Because actually family carers are often extremely aware of the importance of continuing to enjoy food and drink. And for me, this is the key thing. It's enjoyment of food and drink. It's not actually about the nutritional content of the food and drink. It's about the enjoyment. Because exactly as Anna said, there's so much else wrapped up in this. It's not about the nutrition, because I'm betting that not a single one of us here, and me included as a dietitian, looked at our meal at lunchtime and went, I'm looking at all of the nutrients on my plate and I'm making sure I'm getting a completely nutrient-balanced plate. We all looked at the food and went, lovely, this looks really nice, and then tasted it and went, yum, that's really lovely. And again, somebody with dementia is going to be doing the same thing of thinking, that looks nice, this tastes nice, and those are really, really important things. So this one we're doing between us.
Indeed. So I expect if any of you have worked clinically or are working clinically, you might have somebody with eating and drinking difficulties or any difficulties with and you have difficulties about their nutrition. These might be the kind of recommendations that you expect a speech and language therapist and a dietitian to make. You might be expecting us to modify food textures and make them softer and make suggestions around that. You might expect us to make recommendations about thickening fluids or reducing distractions to help people focus or even present the food differently. You might expect us to make recommendations about posture to keep people safer while they're eating and drinking. maybe make suggestions. Maybe even if we had one of our occupational therapist colleagues with us, they might also contribute to these suggestions around, say, utensils that a person might use. Or even, I often, particularly we've been talking about palliative stages quite a lot, I often make suggestions around the priming a swallow, so that, because people aren't getting enough sensory information, so maybe suggesting a sour, iced flavour to prime a swallow. We might make suggestions
about modifying types of foods, so going for sort of easier to eat things that people prefer. We might sort of think, oh, well, it doesn't matter, they can just have cake or chocolate or ice cream or whatever it is. And it's doing things unusually. Oftentimes, I think one of the things that we perhaps shy away from is accepting that people might want to eat unusual combinations of flavours, and that's okay. There's no rule that says you've got to have your main course before ice cream. That's just, we've applied that construct. It's not something that's absolute. If that helps somebody eat, yay, go for it. Fantastic. But we might also think, this is where we need to start having these prescribed products. We need to start having these prescribed milkshakes, because they're magic, aren't they? I'll come back to that in a minute. And then we might need to start talking about enteral feeding, about tube feeding. Is this appropriate for the person? Is this the right thing to do? We're going to come back to that a bit later as well.
In fact, as we move on to the next slide, one of the things we wanted to flag here is that these are all resources that we can use. But what we would say is that no one of these approaches is going to benefit everybody with dementia. In fact, thickening fluids, how many people in this room have had to thicken a drink? Put your hands up. Right? How many of people have wanted to drink that thickened drink themselves? No, right? So thickened drinks are really not very appetizing. And the research evidence, let's take that as an example, for thickened fluids for dementia, it's really practically non-existent. So my experience, and I've worked for 25 years clinically, is that the best scenarios where this is useful is where a person with dementia has become unwell for another reason. Right? So they've fallen and become fractured and had to go into fractured something and gone into hospital and become, physically unwell for another reason. They've had thickened fluids and then they've improved and gone back onto a regular diet. What we should not be doing, what there is no evidence for, is long-term thickened fluids for people with dementia. So these are selected resources that we have in our resource toolbox, but not one of these is going to be a be-all and end-all. And keep coming back to thickened fluids, because we're very, Alison and I feel very concerned. These are often hailed as the be-all and end-all, but as you all highlighted, and I've certainly spoken to my husband about, when I'm in a care home with dementia, I do not want to be offered thickened tea all the time. Maybe, because the other thing is we all fluctuate during the day, and people with dementia fluctuate too. Right? So there might even be times a day when something like a modified diet is a bit safer, but other times a day when that person could perhaps have quite regular foods. All right? So these kind of recommendations are things that we need to, they're not medicinal recommendations. I think that often they are, because they're very medicalised and they're treated almost medicinally, like we're prescribing these. And that's not how they can or should be used, because the evidence doesn't support that approach.
And just to follow up with the evidence around thickened fluids, do we think that thickened fluids improve or not dehydration? Do they make people better hydrated or not? No, exactly the opposite. You are far more likely to become dehydrated because if you're having thickened fluids, simply because most people don't like them. They're not terribly palatable. It is more difficult sometimes to take thickened fluids. And fluids have different flavour profiles when they're thickened, simply because they move through your mouth differently. So you're going to perceive flavours differently. So there's so many things to think about. You might be thinking, this might improve somebody's swallowing ability. Yes, but what are the downsides of it? Will it actually enable them to drink enough to meet their fluid needs when they're probably already on the verge of dehydration anyway? So all of these things we have to think about. It's a complex scenario. So, just doing very quickly about the food side of things. I can't not talk about food. It's not quite a legal obligation, but I feel like it should be. Basically, when it comes to nutrition and older adults, everybody knows what healthy eating is. It's the Eat Well guide, right? For everybody, the entire population, regardless, except for maybe the very, very end. The reality is, yes, theoretically, yes, that is the appropriate guidance for probably most of us. we can argue as long as the day, for as long as the day is long, and indeed probably the year, that maybe it's not quite brilliant for everybody, but we won't go down that route because I'm much more interested in older adults. So the thing that's been missing for a very, very long time is the bit in the middle, what's healthy eating for older adults to prevent frailty, to prevent malnutrition. Only in recent years have we actually had some evidence-based guidance, which the QR code on it will take you to, basically, and this is about what's healthy eating for older adults to prevent frailty, to prevent malnutrition. As I say, it is evidence-based, and I'm delighted to say that the person who actually led on the evidence base is from the University of Plymouth, so lovely and local for us here. And then we move on from that, so if somebody is at risk of malnutrition, which is quite common in older adults, particularly with diseases and disorders, including, of course, dementia, then we might need to think about things a little bit differently. And again, you've got basically a QR code that takes you through to the guidance where I particularly work. But we're looking at still trying to use food to meet people's nutritional needs because, as I said before, food's quite an important part of a balanced diet. In fact, it's, we can meet all nutritional needs with food. And this takes me on to the next bit. As I said before, oral nutritional supplements, things like, the milkshakes, the little bottles, the little cartons, are we all familiar with those? Do we all know what I'm talking about? The Fortisips, the Ensures, the Fresibins, the Ames, the New Ultra, all of those ones. The evidence base for them is extremely small. It is not good quality. There's a lot of it, but it's a case of looking at what the independent evidence base says. And that for me is always a very important point to make, is it's how independent is the evidence base. The two big studies that have been done independently are the two that I've got on the screen, and they basically are saying, effectively, we don't have any great certainty of evidence, we can't make statements about benefits or disadvantages, even though they're being used extensively in practice, so we know these are being used ubiquitously across the whole place, but we don't really know what they do, we don't really know if they work. However, it is reasonable to assume that if there are benefits from using oral nutritional supplements, it's because they contain a range of nutrients, and therefore if we give food that contains a similar range of nutrients, and there's nothing in oral nutritional supplements you cannot get in food, I should point out, we'll get the same outcomes. So again, we're back to, food, that works, doesn't it? And we also have this lovely study that came out, this big systematic review that came out in 2022, looking specifically at frailty and older adults, so even more pertinent to what we're talking about today, basically found much the same thing. My shorthand for this is they don't do what they say on the tin. And that for me is a real biggie. They don't contain fairy dust. It's the one message I would like you to take away from this, because they're not magic. They are not going to achieve anything that food can't. And again, just as we said before, have you all thickened fluids? Have you all provided or seen people with oral nutritional supplements? How many people really, really enjoy them? How many of us would want to have them if we had malnutrition? How many of us would actually prefer to have food that someone had just thought about? Thank you for putting your hand up. And yeah, basically, I'm a dietitian and I'm firmly in the food camp, as I'm sure you can guess. And it really is a case of saying we can do this with food. Food is about so much more than just the nutritional content of it. So we also know that we actually have very little evidence for an awful lot of stuff around food. So there were a couple of studies done back in 2016, so 10 years ago now, really, really good, that found there's no conclusive evidence to say that any interventions are effective or not effective for supporting food and fluid intake. However, what they did say was we'll come up with some ideas for what we think might help, which I felt was a really positive way to basically take this, because you could simply come out of this study saying nothing works, nothing doesn't work. Shrug shoulders, walk away. But they said, no, people still need guidance, which is absolutely right. Most of the studies were small, they're short-term. Basically, when it comes to people living with dementia, they found that carers still need advice. So this was the point that they said, we actually need to give guidance to people to support them, because we really need to support people to make informed choices, because they are going to feel unsupported, generally speaking, through health. And so really what we're wanting to talk about here is what do we know about this nutritional information? And what we know is that nutritional well-being is not just about what people eat and drink. Eating together is a core human activity. What did we all do at lunchtime? We didn't all sit on our own, we sat together and we ate together, and that's a core human activity. One of the quotations that I've seen over the years is that eating together reveals the essence of what it is to be human, which I feel very strongly about, and it comes through in anything like this. Mealtimes reflect our identity, they enable us to make and maintain connections, and that remains for people with dementia. We don't have any conclusive evidence that says that tube feeding, enteral tube feeding, is going to necessarily provide benefit in terms of survival mortality, but no actual studies compare the impact of tube feeding on quality of life or behavioural or psychological symptoms of dementia. It's one-sided, it's one-dimensional. All of these sort of, if you like, clinical aspects of nutrition, they are one-dimensional. For me, food is three-dimensional. All the things like tube feeding and oral nutritional supplements do is they provide nutrients. But as we've just said, food isn't just about nutrients, is it? There's so much more to it than that. It can be such a huge part of quality of life. So it's really important for us to focus on.
And just to add on that slide, there's more evidence that suggests poor oral care can increase the risk of a chest infection than somebody aspirating. Okay, so popping in a nasogastric tube or a PEG tube doesn't improve oral care at all. It's oral care that improves oral care, right? So I guess we're emphasising there aren't, again, coming back to that magic fairy dust, there isn't a single medical intervention that's going to work for everybody we know with dementia, but there are a repertoire of resources that we can use for the right people at the right time with the right conversations. And medications is another thing we need to think about, and that's on the next slide, because medications are something that our clients our patients, the people we work with, have to take orally, predominantly. Predominantly our medications, the cheapest way to prescribe a medication is oral intake, right? And how many people have met patients who have difficulties swallowing patients who've had difficulties swallowing medications, right? Swallowing medications is actually really quite challenging. And the number of times I get questioned, can I crush up my tablet? Can I cut it? Is there another way? Can we put thickener in the liquid pack version of it? Should I just have liquid medications even though they're on, thick? How does this work? Blah, 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 blah. Who tells me? Can I ask the pharmacist, can you prescribe the thickener? Can you prescribe the liquid medications? But they said I can't have them because the liquid medications are more expensive. Oh my God. And it becomes like a sick, I can see quite a few people nodding. Who should we talk to? Is it the pharmacist, the speech therapist, the doctor, the nurses? Who makes these decisions? This one is a real bind. Anyone want to guess what the answer is? It's a theme of today. Communicate.
A word beginning with C.
Communication. Yeah. I think the key is that we really wanted to emphasise that, we have popped a slide up here that might give you some hints and tools, but I think what we really need to be doing is communicating, because if I'm honest with you, when I've actually gone back to the team to talk about this, when somebody's got a significant swallowing difficulty, we've actually discussed whether that person really is benefiting from that medication anymore at this stage in their life. Some patients actually, by that time, if they're on donepezil or memantine, perhaps that's not helping. So we might need to kind of, streamline the medications at this point. To support people more effectively. In fact, I've had a client recently who generally their swallowing improved when we reduced the donepezil and memantine medications, and we focused more on managing their myoclonus. So it was so that their movements was more of a problem. So does that make sense? So we've got to think more personally about these things.
And as coming from working in a medicines optimization team, I'm going to say deprescribe, if at all possible. Look at, are these actually needed? And that applies to everything that is prescribed, whether it's, basically medications or basically prescribed nutritional products, such as thickeners, such as oral nutritional supplements. It's thinking about all of this within the deprescribing, but it's talking to each other. So we've put basically, it's this magic triangle when it comes to swallowing difficulties of the speech and language therapist, the GP and the pharmacist. No one of them has the answer. You need all three of them to get an answer that is actually going to be meaningful and support the patient. And that's why we've got this information up about if you were using thickener and trying to thicken stuff, this is an absolute nightmare. It's not going to happen. You're not going to do it. So it's communicate and collaborate.
Indeed. So we thought we'd just remind you, we've been talking about clinical recommendations from speech and language therapists and dietitians, and the lack of research evidence around it. But let's look at the law. What does the law say? Well, the law says, actually, that people have the right to make decisions about things that affect their own lives, including eating and drinking. And lots of people I meet with dementia, they might not want to discuss this. In fact, we were talking about this during the last task in our group. But lots of people with dementia might find some of these decisions hard to talk about right at the beginning of their journeys, or our journeys with them. In fact, I was talking to some of my colleagues recently about how, in motor neurone disease, we talk about eating and drinking right from the beginning of the journey. We rarely talk about that with people with dementia right from the beginning of their disease journey. And fair enough, they might not, that isn't necessarily a priority, but we do know that it's often the priority of the people around the person, actually. Often their family members start worrying about that right from the beginning. And by the time people have progressed, they might have some less awareness or maybe less ability to generate speech and language to talk about these things. But I would argue, as a speech and language therapist, that people can communicate in lots of different ways through behaviour. And we can often see what people are and understand what people are telling us. I'm sure many of you know, lots of people are smiling now, that people can communicate to us through gesture, and we'll go through this in a minute, but facial expression, all of those things. And they can still flag to us what their preferences are. They can still flag to us, even if it's not verbally, often it is quite verbal, actually. If people don't want to eat or drink something, they're pushing away that thickening fluid and saying no. That can be a very clear statement of preference. And I think that's really important for us to remember, that actually the law says that we should be using all practicable supports to understand what the people are saying to us, and to also communicate with them, right? So when we're talking about eating and drinking with people, we can actually provide options, provide recommendations, discuss options and recommendations. I found in some of the very severe stages of dementia, if we use alternative methods, if we're using all practicable supports like speech, thinking about our pitch, gesture, facial expression, pointing, behaviour, all of those things. In fact, the main bulk of my research is on communication and communication training for the people around the person. Because we found, actually, and I think this ties back to some of all of the talks we've had around communication, but often it's the people around the person, the family members, the care staff, we've all got those skills, but perhaps we don't always know explicitly what the best communication strategies are. And sometimes having that time to sit down and pinpoint what communication strategies work with which people we're working with allows us to make that explicit. And we found that actually communication it's not as simple. We're talking about it in some of today, we've been making communication sound really simple. It's not always that simple. Sometimes we actually have to really practice those strategies. I tell many of my colleagues, who are predominantly neurologists, to talk slowly. And they say, yeah, I'm always talking slowly, Anna. I thought, of course you are. But to actually speak slowly, or to actually leave pauses, or to actually not use jargon is quite challenging. And so communication needs practice. And I think when you're calling on professionals like speech and language therapists and dietitian, I guess rather than calling on them to make recommendations, perhaps you could call on them to help you communicate with the people you're working with to try and make joint decisions around what they might like to decide about their eating and drinking. And maybe that can't happen soon enough. In fact, some of the people I've worked with have said to me, having a communication aid or a communication plan, or you could call it anything you like, an advanced care plan, you can call it all of those things, a personal history book, having one of those, having discussed things about one's own future has enabled them to have a future, have a voice in their own future. Okay, so they've at least, even if they haven't discussed the decision itself, they might have been able to discuss their preferences or who they want to make that decision for them, and it's enabled them to have some kind of voice. And when we're talking about communication, we can't forget documentation. I think care plans is a lot of the communication aids that I've worked on with people, or personal history books, or whatever we like to call them, they look a lot like care plans by the time we've got to an environment like a residential home. And I think that it's really key, and we've been talking about this, Alison and I, that often care plan is really difficult to write sometimes, but often if it's written in the words of the person or in the way the person might have expressed it, it can make it easier for all of us. Certainly I know there is research evidence that shows that family caregivers are much more confident in the decisions they make if they've discussed them with the person in advance. And if it comes from the person or from the person's care plan, they are more confident. So if we're able to write those things down and have those conversations sooner, I think that's a really valid experience.
And just to add to that, just to complicate things ever so slightly, everything that we've said so far, completely valid. But if the person is demonstrating to you they seem to have a different wish now than what their care plan or their basically sort of the advanced care plan was saying, we do have to take what they appear to want now into account as well, because that is very clearly. So if they've said, I don't know, I'll use a silly example, if they've said, all I want to eat is fish and chips, and that's what you're giving them because you're following their care plan, and they're spitting the fish and chips out and reaching for the food on somebody else's plate, I would say they're clearly demonstrating that maybe now what they don't want is fish and chips. What they do want is what the other person is having. And we're not going to continue to give them fish and chips just because that's what it says in their care plan, because actually that clearly is not what that person right now is wanting. So we've got to take all of this into account. So it's not simple, is it? Everything is complex, as we've already talked today. The other thing to say, and I was really glad that this has come up so many times today, I felt as we've gone through the day, how many things we were going to talk about now have already come up in one way or another, which I felt was fantastic, because it felt as if we're almost managing to encompass bits of everybody else's talks into what we're saying today. The needs of caregivers are equally important. Nutritional health of caregivers is of paramount importance, because the reality is, obviously, if you are not well yourself, you are not going to be able to care for somebody as well as you could. Poor nutritional status of caregivers is associated with poor nutritional status of the person living with dementia. So the two things go together. We know this, sadly, this study is quite a long time ago now, but I don't think anything has changed in this. And we know that problems around eating for the person with dementia are more likely to occur when the carer is already under strain. And we've heard this sort of thing all the way through. So it's really important for healthcare professionals, for all of us, to always think about the nutritional status of the person doing the caring as well as the person they are caring for, because the two things are going to run in parallel. They're going to run together. So, swallowing. People with dementia, we're coming to the end of our talk. People with dementia do experience swallowing difficulties, but they might be able to eat and drink different things at different times of day. Similarly, people with dementia might prefer or disprefer different foods at different times of day and on the week and their lives. And similarly, communication. People with dementia might not always be able to communicate to the same level. So people with dementia fluctuate, just like we do. And finding out what people want,
planning for the future, planning, sometimes you can have conversations about a time when a person is not doing so well later in the week. You can plan for that often. But remembering alongside that people are also allowed to change their mind. And people, we've talked about this lots, people with dementia, you've met one person with dementia, you've met one person with dementia. The swallowing difficulties they will experience will often be quite different. And we don't always know what they will look like at different stages of the journey. People with rarer dementias might experience swallowing difficulties very early. People with more typical Alzheimer's dementia might experience swallowing difficulties much later. We can't always anticipate what route that person's going to take. And people with dementia don't always want to talk about it in advance, but family members often do. So we need to navigate that route, and helping people plan for the future, if they want to, is something that we can do. So calling on speech and language therapists and dietitians to do that is exactly how you can use us. So you can use speech and language therapists to ensure, and I hope many people here have seen this diagram before. This kind of encapsulates the entire Mental Capacity Act on one slide. And I've just circled perhaps one of the most important things, point 5 here, principle 5 of the Mental Capacity Act, that what we're really aiming to do is provide the least restrictive option to people all the way through to the end stage of their lives, ensuring that people can make positive risk-taking decisions, thank you, and enhance that person's quality of life. Is that fair? Do you want to add anything?
No, I think basically we're at our 2 minutes, therefore we probably better stop now and wait for any questions.
That's it for this episode of the UK Dementia and Palliative Care Conference 2026 podcast. A huge thank you to our headline sponsor Audley, event sponsor Wallens, and to Dementia UK for their invaluable support. This series is recorded and produced by iNarrator and proudly hosted by Rowcroft Hospice. Links to resources mentioned are available in the show notes. If you found this discussion valuable, please share it and stay tuned for more thought-provoking conversations. Until next time, take care.